So there are four principles involved in designing education to help to improve care. And this has been developed over many years of experience of faculty across the health professions in trying to incorporate quality improvement into their work and into the learning. And so the first principle is to actually assure that you're teaching not just in a didactic or lecture-based arena, but you're also teaching and the learners are gaining knowledge in the experiential setting. So in a clinical setting, in a population setting. So number one is that students need to actually learn about quality improvement and safety, not just didactically, but experientially. The second is that learners really need to have experiences that link them to the environments that they're in. So, for example, in a clinical setting, learners should really be doing improvement work that's meaningful to their clinical setting. There's always lots to improve, but it's most powerful when learners are connected with some of the main areas of interest of an institution. So, for example, if an institution is working on hand hygiene or on patient identifiers, then having learners partner with those projects can be the most powerful experiences for them because they're able to not only see how a quality improvement process can work, but also contribute to their local environment. They have an impact. They're contributing to the system that they're a part of. The third piece is actually to assure that we assess learning. And this most educators would take for granted perhaps, but in quality improvement, a lot of times we do the work of improvement and we may not think about actually assessing the learning that occurs in that. So it's important for us to spend some time thinking about the outcomes. For quality improvement learning, you can always check to see at a base level whether learners have some familiarity with terminology and concepts of improvement, but a higher level of assessment would be able to see whether the outcomes of their projects, for example, are of impact at the level of patient care. So what we're really aiming for is thinking broadly about assessment of learning, not just satisfaction, not just knowledge acquisition, but also moving to outcomes of the patient and the populations that they're invested in their quality improvement projects. Finally, a principle that's important for an educator is to think about being a role model in quality improvement. So not only teaching it, but living it, breathing it, doing it as part of your work. And so being able to demonstrate to learners that quality improvement is a part of your work and as an educator is very genuine, and it helps to model for the students how they can actually do this as a part of their work too. So I can think of an example of faculty members who are a part of quality improvement projects all the time as clinical educators. And so they're teaching about quality improvement, but also modeling that it's a part of their work. As an educator, I try to demonstrate to students in the classroom that we're using quality improvement processes to improve our curriculum. So those are different ways of thinking about being a role model, but in terms of really achieving what you want to in terms of learners having the sense that it's part of their job to be improvers and not just a content knowledge expert of their profession, they need to see that modeled. And so the fourth piece is important about role modeling as well.